I don't necessarily get what you see is what you get with this. It's just another reason why I'm trying to figure out something else. Okay, let's see. This actually is Google Slides, which is what I found I actually had to use with that Pear Deck. So I had to take my PowerPoint and convert it over. So, which means, of course, I had to get it out of, I had to put it on Google Drive and then convert it over to Google Slides, and then to figure out some way to get Pear Deck on here, and then get Pear Deck to work. It was terrible. Anyway, it all was. No, I know they don't want to hear my problems. I get that. Okay, I wanted to kind of, whoa, that's lovely. Get this. Why do we start? Oh, okay. This sort of seemed like a logical place. I know we got past this point a little bit, but just kind of talking about it, just kind of going back a little. You're going to be starting to do surgery at some point here. There's only so many weeks left, so to get everybody in there, we're going to have to start up fairly early. Just a couple of things about this. Just real fast. If it has paper on it, don't touch it. That's usually a very, very good bit of advice. Okay, so when you go into a surgical area here, remember you're going to be expected to wash your hands. That certainly should not be anything of a surprise. You're also going to need to dress out. And remember, they have dressing rooms for all of that, and they have their own scrubs and things like that. Different hospitals have different rules about where you can actually wear their hospital scrubs. All hospitals have a serious problem with scrubs basically disappearing. Let's face it, they're very comfortable. And so they may not let you take them out of the OR. It may be that they will. And remember, we've talked about this. They may have you just wear a lab coat over it so you can go down, for example, to the cafeteria or something like that, or they may not. You may have to wear booties, foot coverings. You may not. You always have to wear a head covering. You will have to wear a mask. You're not set up sterile. You're not in a gown. You don't have sterile gloves on or any of those things. Now, rules may have changed in surgery with the advent of COVID so that you have to wear gloves or something like that, but that would be probably the only major change that I can think of, at least off the top of my top of the head. Okay, the C-arms are called C-arms because quite literally that's what they look like. Now, this little picture right here is showing you the top side where the image intensifier is. The X-ray tube is literally underneath this. And I don't know if this is going to allow you to see the pointer. I've got a red dot on here right now, and essentially it's kind of covering the area where the image intensifier is. If you can see it, somebody let me know. I'm just curious.
Can see it.
You can?
Can, yeah.
So we're gone. All right. I get surprised by everything. All right, there's a plastic bag over it. This is a sterile bag. Now, the surge tech or the scrub nurse who's already scrubbed out and all that stuff is the one who's actually going to start putting this over the C-arm, okay, over the image intensifier part. And you're going to assist in making sure that it's pulled down and is covering over the C part. Which basically is going to come underneath here, go down, and be underneath the table. Because remember, the source of the X-rays has to hit the image intensifier. So basically, it's going to be way the heck down here. Okay. All right. So that's going to be underneath. Now, as you can imagine, getting that X-ray tube underneath a sterile field much like this is a little bit problematic. The X-ray tube is not going to be under sterile covering because essentially anything from about here down is not considered sterile. So you can handle it, but you handle it minimally. And you also handle it on the inside in an effort to keep it as clean as humanly possible. And when you slide that tube underneath. Okay, so this is what I'm talking about with the C-arm. Quite simply, the X-ray tube itself is right here. We talked about this before. There is a spacer, as you can see here, that's basically preventing you from putting the patient's skin directly on the on the X-ray tube, because we know then that the entrance skin exposure would be very, very large and causes burns. The X-ray tube is going to come through and it is centered to the image intensifier, which is what you see essentially on the top side. The C-arm here, like we were talking about, has the ability basically to tilt in all different directions. So you can also set this up. I had one picture yesterday. I wish I had a way of basically drawing with this, but I haven't quite figured that one out yet. Let me see. Anything? Oh, I guess not. Pity that. It has the ability so that this part right here will be over here. That means this part here will come around and be up here, so you can actually get cross-table laterals as well as, APPAs. So you can get both, or you can get some variation in between. You can also tilt this thing to the head or to the feet. Now, when you tilt the image intensifier, of course, the X-ray tube itself is going to go along in an arc. So the X-ray tube, say, for example, would be here, or excuse me, the image intensifier, the X-ray tube would be here. If it goes off like this, then the II would go along like this. And as you can imagine, you can bang into surgical tables and everything else. You get limited range of motion. This thing also extends outward, forward, and back, and that's actually very, very useful when you're trying to kind of get out of their way a little bit. Okay, you've also got, as you can see here, kind of a mobile, I guess you'd call it be the control panel area. So it's like I talked about before, this is where the data is actually entered and all. There is recordings done. You can see here there's images set up on here. There's last image hold. Generally speaking, when you fluoro, that's all about all you're trying to do is to produce a static image. And then that static image is saved, well, if saved if you want it saved, basically, and that's going to be held over here. You can also see they got the monitor going over here. This is for the more modern machines. It certainly makes life a lot easier for you. One of our biggest problems with all of this, let me see if I can back this up. If you can see the way this is set up, you actually would be over here, okay? So you're manipulating this machine and all. The monitor's over here, and a lot of times there's stuff in the way so that you can't actually see what's going on. That obviously can make things very, very difficult. Okay. Now, what you end up having to do for something like that, of course, is reach around, look around, do all sorts of crazy things that kind of get a little bit annoying. There we go. All right. If you have the monitor here, like you do, that's very, very convenient. You can actually see where it is that you're aiming at without looking directly on theirs. Another tip, watch the surgeon. Okay. I'm going to repeat that. Watch the surgeon. If the surgeon is looking at the monitor, then they want something to happen. Okay, so you fluoro. If the surgeon is not looking at the monitor, stop fluoroing because they're not looking for anything. So in a sense, you're almost paying mind to the surgeon until such time as you're doing the fluoroscopy, in which case you're kind of positioning it specifically for the anatomy. But as soon as the surgeon looks away, stop fluoroing. It's unnecessary. Okay. All right. Here's another image. Now, this you can kind of see this is a little bit more of a dedicated system, so this would be an interventional and all, but it really isn't all that much different when you get right down to it from a surgery type procedure. Like I talked about, these guys are in a sterile gown. They're wearing gloves. They have masks on. They're not wearing hats. They probably should be. And as you can see here, this is a fixed C-arm system, which I said is what you would typically would see in an interventional system. So they might be doing something in here, for example, like cardiology type stuff, a cardiac catheterization and all. Notice that we've got a table that's set up on the opposite side. The other day, we were opening up, what do you call it, trays and all. And it's a very good idea to go to work and go back and review that if you haven't done so, reminding where you start, okay, what you do next, and so on and so forth. The other thing is we have plenty of sterile gloves. A little bit of practice once in a while probably would be very, very useful for everybody. All right, where'd my picture go? All right, that is not elegant. All right, I'm not making any claim that it is, and we talked about this the other day. One of the reasons why I have this picture is because of how kind of crazy looking that image intensifier is set up. So in this particular case, the X-ray tube is over here. Again, it has its spacer and all protecting. The radiation is coming through, and of course, it's going to hit the II, which is essentially between the legs, because this is basically done for, roughly speaking, okay, a cross-table lateral hip. Now, generally speaking, I would have thought we would have this thing in a little bit more of a horizontal position, but this is where they've got it. What am I to say? Now, the interesting thing is you notice that they've got the patient in this type of device, and I think if memory serves me right, I told you that one of the things that they do here is to basically get the bones together so that when they actually put the pin in, it's actually in place. So they have to actually put the patient in traction to do that. Please notice, incidentally, that in case you were wondering, there is this large device right here that's keeping the patient from basically getting dragged off the table. This is what's called an orthopedic table. This is not a typical surgical table, obviously. This patient is not basically been scrubbed for surgery or anything like that. Like I said, they're doing preliminary work in surgery. But the work that they're doing, they would not do with this patient awake because it would be very, very painful because what they're trying to do is to set the bone. Okay, so just kind of a reminder with all of this, fluoroscopy is where you're going to get most of the radiation. The things that I was fighting with yesterday was talking about radiation protection and the technologists, the personnel in general. And nothing has changed, whether or not you're talking about it from working from a surgical perspective or GIs, or quite honestly, from radiation protection and biology, it still doesn't change. Fluoro is where the majority of this happens. Okay, you have three different elements of what we call the cardinal rules of radiation protection, and they still hold. Okay, you don't have control over the time. That being said, there is a monitor there. There is when it fluoros, it goes beep. You can, if you are controlling fluoro in surgery, watch the physician. Remember what I told you, because if they're not looking at the monitor, take your foot off the pedal. Shielding, everybody should be wearing shielding. I think I talked a little bit about the fact that sometimes the surgeons are a little bit lax in this. They'll wear a skirt from a two-set, a wraparound, but they won't wear the top. And again, it's because of the weight and because it's uncomfortable and all. Guess what? Tough. Now, those aprons and all that stuff are going to be underneath their sterile gowns. So they will go into scrubbing for surgery with the apron on. So as you can imagine, the device, whatever you want to call it, the hangers that the apron's on are visible, immediately accessible. So if a surgeon walks into surgery, they can just pick up their apron, go over, and then get started. So everything is basically underneath their sterile gown. And lastly, there's distance, and distance is where you can basically protect yourself the most. Now, the operating room personnel can't necessarily. They're kind of stuck where they are. But you, on the other hand, can always just take that extra step. And remember, that's the most important thing you've got going for you. And I just put this up here, again, just to kind of remind you where's the distribution of scatter radiation. And if you've looked at the PowerPoints that I had posted up there finally yesterday, you also could see that keeping the image intensifier as close to the patient is very, very important. Now, remember, when you're dealing with something like surgery, that can be a little bit problematic because you can't be but so close. But because it's basically you've got an open, surgical case going here. But you do the best you can and get it as close as you dare. And remember, it's also going to be covered with a sterile plastic cover. All right, here's some best practices, and I'm going to tell you right now, I will put pictures or pictures like this on there so that you can go to work and tell me that you understand what best practices are. Part of the reason for this is that, as I kind of dictated yesterday, there are doctors out there that simply don't understand. And by which I mean is that the X-ray tube being on top is a very bad idea in terms of the radiation dose. Now, I'm not talking necessarily about the radiation dose to you, but to them. Sometimes you have to protect the little darlings. Okay, so you want the X-ray tube under the table. Okay, so whether it's a surgical table or whatever, X-ray tube underneath. Okay, the table itself functions as an attenuator and serves to protect basically the operators. So this bad, okay, this be good, okay. Now, how about the other one here? And I've talked about this just a little bit. When you're dealing with the C-arm, you actually have some flexibility, some, not a lot, but some. with positioning the tube, and that's been the reason why, they talk about it. It's 15 inches if you're talking about a fixed system. It's 12 inches. There's that little bit of flexibility there. That being said, you want to keep the X-ray tube as far away as you can get it. So when you're raising it up and down again, okay, well, you don't want it hitting the floor, but you got a balancing act going there in surgery, and I think that probably is about the easiest way. You want to keep the eye as close as you dare, and also keep the X-ray tube as far away as you dare. That might be the best way of putting it. Okay, now how about you? All right, now in general with fluoro, okay, and so I'm kind of talking about this is not hard, fast, just for surgery. Most of this is common sense, okay? You try to get as far away from the X-ray tube as you can, okay? What I basically used to do was, well, since I was one of the first person in the room, because I had to get the equipment in there and all that stuff, is that I basically get myself a stool, okay? Kind of put it over there by not the monitor, by the machine, and essentially just kind of push it away a little bit. You are not fluoroing the entire procedure, okay? You're only fluoroing when they got something to actually look at. So it's perfectly okay for you to sit down, should you happen to have a seating there. And you can also kind of keep it further away. When you are handling the C arm, generally we are holding onto the C part. So we are fairly close, but the problem is that because the machine is so fundamentally clumsy to begin with, you can't stand from behind and push it back and forth, not so easily. So you have to do your best to basically stay as far away when it's actually flowing. All right. Look, here's one thing I should point out. If you're moving the tube all over the place, unless they are literally following a line or something like that, if you're moving the tube, you shouldn't be fluoroing, because who wants to look at motion pictures? Um, if they are pushing, let's say, for example, a line in like a pacemaker, a Swan's Gans pulmonary catheter, then yeah, you would be following the line as it goes along through the heart. That's usually about it. All right, wraparounds are still the best, especially in surgery if there's any situation where you're likely to turn your back to the X-ray unit. Otherwise, you're stuck with facing the unit forward, which can be something of annoying. All right, now, as I've told you before, and again, this is just general fluoro rules, okay? Don't stand near the patient unless you absolutely need it. I'm not telling you to stand in the control area. That doesn't ever look good. Stand behind the radiologist or the machine or something like that if it's a C-arm. Keep your hands, basically, if you're talking about in a regular GI room, keep your hands actually inside the apron, okay? You can kind of like, almost like, where else you gonna put them? Or put them behind your back, and sometimes that's a little uncomfortable. Usually stuffing them into the apron itself is about as easy as anything. Remember, when you take the aprons off, do not chuck them someplace. They are made of lead rubber, and the lead rubber can crack. So be very, very respectful. Don't throw them on the floor. Don't throw them anywhere. Don't fold them up. Make sure that they're all hanging up properly. You're going to see the whole throwing aprons around type of stuff going on in surgery. Okay, taking a deep breath. What can you say? Pick them up and hang them up properly. That's what you're supposed to do. All right, this is where I was kind of hoping you could do this, and I guess probably we can't under the circumstances. This was the idea, was she was supposed to be able to push one of these things and all. If you go through the interactive deck, it should work. At least it's supposed to. Who knows? I'm working on it. Okay, so we've already talked about this. Let me kind of move on. We talked about all of this. Remember the surgical team, you're part of it, okay? Now, you, like the circulating nurse, are not scrubbed in. The anesthesiologist is not scrubbed in. Surgical team, as you can kind of see here, are going to be a combination of scrub nurses, surgical technologists, surgeons, assistant surgeons, and the like. In a lot of cases, there are two surgeons in there. Let's face it, two pairs of hands are always better than one. All right, let's see, we already talked about this. Yeah, okay. This is a good rule, okay, which is if it has a paper sheet on it, okay, it's sterile, so don't touch it. If you are in doubt, don't touch it. Um, you know, just don't touch anything like that. There are things that are not sterile, like you, okay? The monitor is not sterile, but part of the CR, remember, is because it's going to have that plastic on it. So keep that in mind as well. Come on. All right, let's kind of move on because that didn't work either. So under circumstances like this, this is, again, we kind of got an interesting situation. They have the patient all scrubbed up. That's the technologist, presumably, and not the surgeon, simply because we're not scrubbed up. Um, you can see the plastic on there. Okay, yeah, I think this is closer to where we left off last time. Remember, that's generally speaking the areas there. That's a good picture for showing you what is considered sterile versus what is not. Okay, remember when you're opening up a sterile item onto a sterile field to come in from the side and don't reach across it. Don't touch sterile items if at all possible. If you do, okay, if something accidentally happens, make sure that you tell somebody. Don't hide because you're unhappy and stuff like that because you're going to get into trouble, okay? That's not the problem. We're trying to make sure that the patient doesn't get a bad infection, right? So recognize that. Anytime things get splashed or spilled, it's considered contaminated. So, for example, if you were pouring betadine into a cup or contrast media into a cup and splash, they undoubtedly would go to work and remove the container and then put a sterile towel over the area to try to keep it clean. All right, so this is the plastic that I was talking about. There's sometimes a two-piece, sometimes it's limited in only one piece. If you look very, very carefully at this, they're going to start from the image intensifier and then pull the whole thing down, okay? The surgical tech or the scrub nurse is going to start by putting it on, okay? She's going to keep her hands inside because that's where the sterile part's going to be. And then eventually you're going to basically kind of come in here, get it all the way down like this, and then through a combination, they're going to basically put flaps on there. And there's some people that like rubber bands and things like that, just to keep it from flopping all over the place. Please notice the X-ray tube is not covered, okay, because that's going to be, or it should be, underneath the table, which isn't sterile anyway. All right. Now, talk a little bit about some various procedures that you might see. The term operative cholangiography, well, operative is pretty obvious. Cholangiography may not be. Cholangio is talking about the biliary ducts. So operative cholangiography is a radiographic examination of the biliary ducts, and this is going to be occurring post gallbladder removal, post cholecystectomy. What they are typically looking for something like this is any residual stones. So what they'll do is that they will cannulate the common bile duct. They've already taken out the gallbladder. They've taken, they've closed off the cystic duct. They will manually inject contrast media, iodinate contrast media, into the common bile duct. And really what they're doing is they're looking to see if there's any stones. Now, as you can kind of imagine, they don't want any air bubbles in there either. So they're very, very careful about all of that. You simply fluoro during these things, take those pictures like we talked about, like last image hold, and it gives them a chance to evaluate their work. So that's operative cholangiography. That's typically going to be a fluoro study. Every once in a while, you might get somebody that does something different. Okay, it could be done with clean films. If they do something like that, then you're simply going to work and have the patient, or the patient, the physician, the surgeon is going to inject into the common duct. What you do is you get the anesthesiologist to basically stop the patient's breathing, and then you can make the exposure. Okay, most of the time, though, by far and away, C-arms are just simply easier. Okay, hip pinnings, especially if you come from where I come from, the land of the ice and snow, hip pinnings are pretty common. So this is, like I said, this is not a true surgical table, it's an orthopedic table. And you can kind of see how extending from the table out here, you've got the devices there for holding on to the right and left legs. And remember now that they can use this for either one, But what they're going to do is use this to put traction on the leg to get the bones back into alignment. And they'll keep that traction on there and then go in and do surgery. So again, it looks like a crowded mess here. You can see that there's nothing set up sterile. They're simply basically working now to align the bones. So before we ever do anything, this is one of the first things that you're doing in there. I mean, now, is it possible that there's no displacement and they don't need you for this part? Yeah, but it's not very likely. Okay. Now, I wanted to call your attention to something. They have a framework over here. Okay. The X-ray machine is on the other side because remember what they're going to end up doing. Okay, is they're going to be bringing this down and this up to shoot laterals. Okay, this is what we call a shower curtain, or at least where I come from, we call it a shower curtain frame. What they're going to do is they're going to have a sterile piece of plastic right here, and it's going to be basically stuck on the leg. So everything here, for their purposes, is either sterile or it started out as sterile. Incidentally, there's your anesthesiologist or anesthetist. Okay, so what kind of fractures might you see? Well, I believe I sent you guys a video that we're talking just a little bit about these things here. There's intertrochanteric fractures, which means essentially it's going to be going through the trochanters. So I know this says subtrochanteric, but it's some variation as you see. There's also subcapital fractures, and subcapital fractures used to mandate that somebody have a hip replacement, but that isn't necessarily the case anymore. Okay, if you take a look at the two setups here, you can kind of see how the surgical approach is different, whether or not you're talking about trochanteric type of fracture or a femoral head fracture. They're simply using nails with the femoral head fracture. They're going to end up posting this and using additional nails, basically, as you can kind of see here, along with a plate to kind of control basically the different moving parts here. So you will see something like this when you go into surgery. There'll be a surgery board, probably a electronic monitor, although it could be actually just written out, and they'll give you an idea of what type of fractures you're talking about there when they're talking about a hip pinning. All right, so first step for doing a hip pinning, or quite honestly, any kind of a fracture, is to simply reduce the fracture. In a lot of cases, fluoroscopy is necessary for that. Okay, you can fluoro to check to see whether or not they did a good job with reducing the fracture. Okay, they'll do the surgery and they'll put in guide pins, and same thing again. They will fluoro to go to work and check to see if the guide pins are in the appropriate place. Now, the guide pins are the things, the devices they're using before they put in the permanent pins. Okay, reams the femoral neck. Now, we're operating on the assumption we're going to be inserting pins literally into the neck. Whether or not you're talking about intertrochanteric when you have the large pin, or whether or not you've got the nails that you have here for subcapital. Okay, now the nails are typically called Jewett nails, or if you're doing, like I said, intertrochanteric, you put that rod in place. And then you check alignment again. A lot of times, these patients are going to have all of this stuff done. They're going to be moved to recovery, okay, ACU, and a lot of cases there will be x-rays taken there as well, mostly because of so much motion and movement going on to make sure that everything still is in place. So in some places, the surgical techs are responsible for handling PACU stuff. In other places, it's just going to be the people that are doing portables. You know, if you're free, that type of a thing here. All right. So this is an example of a, well, you can see there that there's a femoral neck fracture here, but I would kind of call this more like subcapital. And what they've done is they've inserted screws into place. So there's a surgery procedure that's going on. They've opened it up over here, okay? And what they've essentially done is they put in the 3 screws. And they're going to put the screws in. You have to kind of think 3-dimensional. Just remember now, there's also depth. This is not a small bone. And they are essentially to fix that femoral head in place. And it does a pretty decent job. All right. When they are doing a plate along with a large pin, this is typically done, like I told you, because of some kind of an intertrochanteric fracture. Okay. They're gonna, as you can see here, they're going to be coming through along this way. And then the plate here is actually kind of on the outside. So it kind of depends on where they're approaching this. You're going to have to, again, look at this from the other dimension to see that this is actually superficial. And you notice that they've got a nail in here, and that's just essentially to hold this thing inside the medullary canal. Okay. Anytime you are taking any of these types of x-rays, always get the whole pin on the x-ray. There are no exceptions to this. If you want to get written up, and you should be, just clip a pin and pass it and send it through. Here's the reason why. As patients age, these pins basically sometimes can move. Now, they move because of wear, they move because of tear, they move basically because the bones start to deteriorate. If the pins become loose in there, they become very, very unstable, and you're running a very severe risk of a femoral fracture. So what they're looking for in a lot of cases is what's going on right down here at the very, very bottom. If you don't put that on there, and let's say, for example, somebody has fallen, and you don't put that on there to indicate whether or not there's loosening of this pin or not, then you haven't done your job, okay? All of the pin on the x-ray. Okay, so what do we call all of these procedures for basically for repairing bones? There's a couple of different terms, but the most common one that you're going to care about is going to be open reduction internal fixation. Open reduction means that you're doing a surgical procedure. Okay, so you're cutting somebody open. It is possible, for example, to do a closed reduction. So let's say, for example, somebody breaks their wrist. They come to the emergency room. The orthopedic surgeon comes in, manipulates the wrist. You could feel it. Gets the bones into alignment. Gets passed on, and all good. That would be a closed reduction. An open reduction means they're going to open up the skin. Okay. An internal fixation essentially means they're going to be putting pins in there. And that's the big reason why we come into a surgical case. So, again, when you come in the morning, if you check in the OR schedule, that's one of the words that you're typically going to be looking for, ORIF, or abbreviations if you'd like. And again, it has to do with, okay, this is one that somebody's going to be in one. Okay, this is an example of a fluoro shot that's done of a wrist, which is an open reduction internal fixation. Okay, they've opened up the wrist, and what they've done is they put, as you can see in here, a plate essentially along the radius, and then they've inserted a bunch of screws in there to help hold it in place. As a general rule, and I'm going to call this my observation, the more screws that they use like these, I shouldn't say pins, they're actually screws. The more of those they use, it's because the bone is weaker. So a good healthy bone probably does not need this much anchoring. A bone that's kind of osteoporotic, probably a few more. Okay, so this is kind of what actually goes on with something like this. You're looking at the lateral aspect of a foot. This is somebody who probably had a bimalleolar fracture. Bimalleolar means both malleolus broke. Typically, the fractures are going to be down here at the lower end of the tibia and a little bit higher up there on the fibula. So you see what they've done is they've inserted a plate in there and they've put in a few screws. They actually use a electric screwdriver. These guys are an awful lot like fingers, and just basically to hold that plate in place. So once they've done that, they close it up, you're all good. And this is what you typically see on your x-rays following something like that. So this would be what would happen from a BI malleolar fracture. Okay, 2 screws over here to get the other malleolus in place, and then plate with screws here on the fibula. That's pretty typical. Okay, again, here's a couple more. Same basic procedure. All right, now, how about PICC lines? Okay, these are peripheral lines that are inserted, okay, and as you can kind of see from the picture here, they're going to get inserted all the ways into the superior vena cava, almost into the heart, almost into the right atrium. So they're at that junction right there. PICC lines are very, very useful for example, medications, things like that. They can be used incidentally for contrast media if they are rated for that kind of pressure. Okay, you have to kind of check on those. So PICC lines are done sometimes utilizing fluoroscopy, sometimes not. I think a lot of this has to do with whether or not somebody tried it and it didn't work the first time. So they're going to start in the antecubital vein. It's actually the medial cubital vein. And what they're going to do is just simply thread it through the veins, the deep veins of the arm, the axillary region. So it's going to be up here into the axillary arteries, into the axillary veins, into the subclavian veins, into the superior vena cava, like I said, and kind of stop it right there. And so these are very, very useful. They're not a permanent solution to a problem. Eventually, somebody may have to have a long-term dwelling catheter put in, like a Hickman or something like that. Those will end up being put into a subclavian vein. So this is the type of picture that you might see if you are talking about a PICC line. First of all, you're not required to get the whole arm in there to demonstrate that, but you kind of need to be aware of why you're doing something like this, because in theory, these things can kind of, because they're kind of spaghetti-like, these things can kind of get all folded around and things like that. So you kind of want to make sure that you get at least a little bit of an idea of where things are starting from. So what they've done, like I talked about, is they're coming up here through a brachial vein, axillary vein, subclavian vein, brachiocephalic vein, and then down into the superior vena cava. Your responsibility for doing something like this is ensure that you can see, in other words, the x-ray is straight and it's penetrated enough to see where it ends. That's what you're looking for. You may do other types of lines, quite honestly, like for a pacemaker that might be coming down through here. Again, you have to have enough penetration to ensure that you see it. Okay, some other types of procedures that you might run into. Retrograde pyelograms are surgical procedures. Now, these have been done both with plain radiographs, much as you kind of see there to the right, and they've also been done under fluoroscopy, as you kind of see to the left. In both cases, these are done under in surgery because of anesthesia, because they're not particularly comfortable, as you can probably imagine. They're inserting a cystoscope. I think I had a picture of that here, didn't I? Yeah. They're inserting a cystoscope essentially into the urethra. And what they're going to do is to basically put that scope in there and kind of check things out. And you can kind of see these can be kind of big. Back up just a little bit. Okay, so what they're trying to do at this point now is to insert a wire or a cannula, better word, I think, into one or the other or both of the ureters. So they're basically looking for that orifice there that's going to be on the back part of the bladder, put the cannula up in there, and then inject. Okay, when they inject, as you can kind of see here, you might see evidence of a congenital malformation. So what we've got here is two ureters. Now this one apparently is going up to the kidneys, but this one here may not. It may be just kind of blindsided right there. That could be a source potentially of infections. Okay, the one that's over here, what they're doing is they've injected the same way, and what they've identified there is a large mass that's causing a major displacement there inside the renal pelvis, the renal hilar region. Okay, so again, these are done as operative procedures. They're usually going to be fluoro studies. They're definitely going to be a sterile technique. You have to keep in mind that basically the whole kidneys, bladder is a sterile environment, and they're going to keep it that way because nobody particularly wants the urinary tract infections. Okay, so what we are looking for is going to be the bladder, all right, ureters mostly, and the renal pelvis. You will not see the renal cortex or medulla, okay? These are pyelograms. And what I mean by that is you will demonstrate the renal pelvis and the calyces, but it doesn't go any further, okay? That's why it's called a pyelogram, as opposed to a urogram. A urogram, remember, the contrast media is going to go into the renal cortex because that's where it's filtered from the blood. into the renal medullas, then into the renal calyces, pelvis, so on and so forth. This is a little bit different. Incidentally, you're using sterile contrast media, and this is iodinated, non-ionic contrast media. Okay, so they can also incidentally do something like remove stones this way. They'll use a clip to basically snatch it, or they might use a basket to type of trap it. There's a couple of different ways they can handle this. This will require using a combination of the cannulas that I was talking about and wires. So they can actually go in there and actively treat the patient, for example, for renal stones, for nephrolithiasis. And, you know, that's obviously is a good thing. It's not just a diagnostic procedure. They can also put stents in there as well. Okay, the last couple of images here. Okay, one thing, I wanted you to look at this very, very carefully. And I'm very serious about this. Take a look at everything that's going on here and try to imagine how you would get an x-ray machine, like a C-arm, in there and x-ray that from an AP and a lateral perspective. I'm going to give you a few minutes to just take a look at this thing, and just because this is the type of stuff that you're going to come rolling into, and somebody's going to at the last minute say, I need fluoro, I need an image. And then you just, okay, here we go. What would you do? While you're doing that, I'll drink my coffee.
Well, I've never touched Xeon before, so
It's a little hard, huh?
I
Well, see,
can't
please
even.
remember, everybody is supposed to have worked with the C-arm, at least practice with it at this point. That's always makes everything difficult. Would you agree with me that it's going to be clumsy? Yes, I hope. And you also have a wide
Yes.
open wound there, so everything has to be kept sterile. As you can kind of imagine, that can be very, very difficult. There are pins in there, so they have fixed the fracture already. So the guy can turn the hand back and forth. You see how basically two of the fingers are in that Chinese torture thing there, with that little frame? All of that is sterile. So they can actually turn the hand to left and right. So one thing that they would do would be to cover the open wound with a sterile towel, and wrap it around that way so that if something accidentally happens, they can do something about it. Okay. They might make you come in if this guy was being a really, I won't use the word. They could take the guy off of the traction, which is what they essentially have going on there, and put the arm down, and you take left and right, do AP and lateral, or you're going to have to simply manipulate the machine in there to get the images. I want to call your attention to something else. If you look down by the elbow, okay, essentially what you have on there is a tourniquet, okay? They have a limited amount of time that they can spend doing these procedures because they have cut off the blood supply in an effort to control blood loss. So they have a limited amount of time, so they have to keep track of all of that stuff. So there's no dithering around basically on these type of surgical procedures. Okay, now here's another one. This was always my utter favorite, except mine was trying to find the cervical spine. You can see we've got a sterile table over there, and you've got basically a surgical assistant, perhaps slash scrub nurse. Surgeon over there is getting started. We've got everything is all gowned up and draped up and all that stuff. And where, oh, where is the lumbar spine? That's a joy, isn't it? Especially when you're doing this from a cross-table lateral perspective. The head is up there by the IVs, I'll tell you that much. Okay, and that you're a little bit shooting blind because you can't see anything. This is where your exquisite knowledge of anatomy comes into play. As you can imagine, it's not that easy.
Mhm.
this is what I was kind of hoping for to get a little bit. Like I said, I don't know that it actually worked all that particularly well, but the idea was to get a little bit of an idea with what you learned versus if you had any further questions. And what we were hoping to do, I'm hoping to do, basically, if I get this worked out, is to have this going real time. Um, I think we're probably going to have to present this in something other than collaborate to make this work, but this is still a work in progress, as you can kind of imagine. So my question to you then basically is, do you have any questions?
Miss Kendall, when you're in surgery trying to do the X-ray like with the hand, do they move out of the way or do you have to just work around the doctor?
They'll move a little bit out of the way if they can. If it depends. It depends on the situation. If they're trying to hold something in a particular position because let's say it's really unstable, they're not going to go anywhere. I kind of wish sometimes they would take that step back, but you also have to understand that they have to respect where the sterile field is, and there's really only so far they can go. So they can't too much. That's one of the reasons why I quite like, for example, with that wrist, let me go back to that thing. Um, here we go. With that wrist right here, um, they almost undoubtedly have lead shields on underneath. Now, you're not required to ask them if they have lead shields. I mean, if they had any chance they had fluoro, that's their responsibility. And they're not going to break scrub just so they can take a quickie AP and lateral to check to see where their guide pins are. But you, from something like this, remember, what they're probably looking for is a static image, which means you can utilize the last image hold, which means you just zap it long enough to get a decent image, and then take your foot off. And you can also collimate this a little bit, but that tends to be a little bit dicier because remember, time is an issue. So we're not there to be Picassos. You're not there to finesse things. Just get the image, basically, and get the patient basically back, finished is really what it gets down to. So it's not easy. It's not easy. But by the way, it's very doable because we just do it all the time.
On this
Oh.
image, it's for a wrist, right?
Yep.
And so would the finger position matter?
No,
Okay.
no. You see how they get, like I said, they got that Chinese torture thing going there. What they're doing here, this is not diagnostic to say rule out fracture. This is basically being done to say, do I have my pins in the right place so I can get this finished? Okay, that's what they're doing here. They're putting in guide pins. Now they may end up putting in plates and screws. I mean, it depends on the particular surgery that they're doing. They may not. They might just leave the pins in quite literally and just clip them off. It sort of depends. But what they've done, see, like I tried to allude to earlier, okay, there's kind of like steps to all of this. And step one is get basically the bones reduced. So you get them basically in alignment, you fluoro. Okay. Step two is when they're basically putting in the pins. The bones are aligned, they're putting in the pins to get everything squared away. All right. To determine is it stable enough and things like that. And now pins can be the initial guide pins slash the permanent plate and screws. Okay. And then essentially step three is that after everything is done and closed, do we have permanent pictures, which you can do again with that last image hold. So like I said, you're not fluoroing the whole time for these, not for pinnings. It just doesn't happen. You're there sitting there for part of the time when they're basically working. Anybody else? Ms. Hibbert, do you have anything to add?
No, just like you were just mentioned to them earlier, as far as them getting into surgery once they start back in the fall, that we
Right.
definitely will have them get exposure to that. I think the only student that I've heard talk about it so far is Jalen. I think Jalen has actually been in surgery at some point.
Okay. All right. Well, that's okay. Jalen, are you there? Is he awake? Jalen.
He wrote, "Yep."
You can't see it, but
I'm
he.
glad to hear that, dear. Oh, yeah, you're right.
He wrote, "Here today."
Okay.
I'm here today.
Okay. Happy to hear that. Okay.
Yeah.
You've been to surgery?
Yeah, I did a open reduction hip.
Okay. Can you give us a little bit of I know it's been a while. Can you kind of give us share a little bit your experience?
Oh, it was cool. All you did was keep taking a AP and a lateral, and like you just know the positions like before the surgery starts, whatever. You just make sure you know what degrees you're gonna rotate the C arm, and every time he look up, just take a picture until he tell you change the position.
Mhm.
So you take like 90. I took like 90, I think.
90?
Yeah, he kept wanting pictures like every 2 minutes. I was like, geez.
Yeah, it seems like a bit much. I must have been a complicated one.
Yeah, it was like a really,
Sometimes,
really, really old lady, like 80 something years old.
yeah, there you go. Yeah, they're trying to stabilize something that's probably not stabilizable. The other thing is you've seen pictures of fractures that are comminuted that have many, many pieces. As you can probably imagine, trying to put that together is a little bit, what is that thing called? Jenga?
Yep.
So, yeah, I mean, you get all those little blocks, and basically, if you pull one out, the whole thing comes down. I have literally seen that happen. They have everything put together. They just simply go to work and move something, and it's like the whole thing falls apart. And I think it's kind of like what your case was they had a really, really unstable osteoporotic mess.
Probably.
So, but like I said, there is a limit to how long they can do these things because of the tourniquet, and also, quite honestly, because of the, anesthesia. I mean, how long can you keep people in anesthesia? Yeah.
Hmm. Interesting.
Miss Kendall, I have
Anything else?
about the
Go
home
ahead.
about the interactive. You put it up for us to go through on the interactive thing.
Yeah.
The question that you're asking about the table, it looks like it says the two or the letter I. I'm assuming you meant the tube. I'm not sure.
Image intensifier.
Oh, okay.
Okay. There's the X-ray tube. I'm sorry. I meant image intensifier.
Can I go back and answer that? Because I thought it meant the two.
I don't think I've closed it yet.
That definitely was opposite. I mean, I guess.
Yeah.
Okay.
See, this is how you figure something out. All right. Any other questions? Do you have something else you want to proceed with, Ms. Hibbert? Because I guess I'm done.
Yeah, if you're done, I'll just go over the test that they did last week with them really
Okay.
quick, and,
All right.
and then that's all I have.
All right. Guys, if you want, I've got the Quizlet open, and if anybody's interested in doing a review for the test for tomorrow, I will come back in through here. I don't know how much time this thing is actually set up for, but after Ms. Hibbert's finished, I'll be more than happy to try to get in there and let's see if we can't do a little bit of review. If you'd like, it's not mandatory, okay? Other than that, y'all take care. I guess then I'm going to go kind of close myself out, at least for the moment. If I can
Okay.
figure out how to do that. Take care.
All right. Okay, guys, let me just get the test pulled up and we could just review that. I think it should just take us maybe like 20, 25 minutes or so to go through it because there was only 28 questions, so.